Cindy?
So does this tell you basically that navigation itself is a successful program, or is it telling us that we're, due to navigation, our disparities overall, we're shrinking that space, I guess, between the disparities?
Yeah, and I think what it shows, I mean, I can't tease that out right now. Though there is, when I go ahead and put the navigator into the regression model right now, you know, I don't get a lot of noise, but part of that is that the data are so good, there are so few people not doing well right now that, you know, it's hard to see the bump directly attributable to the navigator. But I suspect it's a combination of things. I think it's a combination of the leadership of the Cancer Center saying transparency is important and we're going to look at our data, and everybody understanding that. So I think that's a factor. I think that navigation is a factor. So I think it's all kind of coming together.
And the real-time registry.
Yeah, except the real-time registry doesn't explain the total population bumps. It does explain the great data for the registered patients. But again, I mean, the presence of the real-time registry creates a certain awareness and transparency that may be spilling over into the rest of the care. Because, well, let me ask you this. How subtle is Beth? Do you know if she's around?
Are you asking the audience how subtle?
Yeah.
I think she's very visible. I mean, I see her in the clinic a lot, and especially the way she works with our current breast navigators and lung navigator.
Yeah. Yeah, so again, the enrollment of the study, I mean, there are some patients in the study, everybody's been enrolled. There are some patients who haven't reached the treatment measurement dates yet, where if they don't get treatment by such and such a date, that they count as getting no treatment. And so for breast cancer, that's something like 150 or 180 days. 180 days for lung cancer is 120 days. And so there are a few patients that haven't reached those thresholds and aren't reflected in the data. But for the most part, the enrolled patients that are going to be in here are in here. And we already know that, you know, their treatment has been very successful. What we're really interested in is, remember, the total population data comes from the cancer registry, and there's a 6-month delay between cancer registry data getting into our data. And so because of that, we haven't necessarily reflected the entire gains, total population gains that we'll see.
Do you think that this study could ever lead you to looking at the time that, you know, of diagnosis in the disparities? I mean, think about the community, and how long does it take the African American to seek health care, and how does that affect outcomes?
Yeah, we don't have delayed diagnosis. Well, we do kind of have delayed diagnosis in that we've shown that African American women are about 12% more likely to be stage 2 rather than stage 1. So there is a late stage shift for African American women. Part of that is delayed diagnosis. A small part of it is more aggressive disease pathologically. Black women tend to have more triple negatives, although, you know, in this population, that number would be so small you really wouldn't see it. But yeah, there's presentation at later stage, so there is a need for an effort to get women into mammograms earlier. So that's true. And then you got a question.
Yeah, also, besides the navigation process, both of these diagnoses, we also have the breast clinic and the lung clinic where patients get the multidisciplinary care. And, I don't know if you can tease that out to see how that factors.
Yeah, that's really interesting. And we, in a study that we did that went from 2005 to 2009 that was done here. This was one of 5 sites. But, so at that time, we just looked at lung cancer, and we did look at multidisciplinary clinics, and at least in that database of 400 patients, the multidisciplinary clinic didn't make a difference. And the reason for that, I suspect, is, so I've been going around to places in Pennsylvania, South Carolina, North Carolina, all the places we've done these studies, and I've been attending these multidisciplinary clinics. And what I can tell you is some of them are true multidisciplinary clinics where the patient is presented before treatment and the entire group gives their thoughts transparently. And when that happens, it adds another element of transparency, right? Where multiple people are aware of the decisions that are being made. So that tends to systematically prevent any biased decisions. But in some of these multidisciplinary clinics, there's a dominant provider who has already done something to the patient and presents the patient after the fact. And those multidisciplinary clinics don't work as well. Because obviously the decision's been made somewhere back here instead of the transparent process that a good multidisciplinary clinic has. So, one thing that's thrilling to me is this is an excellent place. Having spent 20 years of my life here, it's good to know. Good to know. And so I think now there are 2 things that we really have to be mindful of. Number one is, how do we maintain the momentum when the study is gone? I mean, can we build these systems that we're talking about as a permanent fixture of the cancer center? And number 2 is, can we apply it to more of the cancers and more of the treatments? And number 3 is that there are still some nuances to work on, particularly we talked earlier about palliative care and symptom management, and the fact that there were significant differences there between African American patients and white patients in terms of their feeling that their symptoms were being dealt with in a timely way, especially pain symptoms. So there's still work to do, but dang it, you're doing good.
You mentioned African American, and there it says black. How are blacks and African Americans or whites being defined? For example, Latino whites or continental African blacks or Latin black? I mean, like
it's just black and white, regardless of origin of the black person. And that happened to be how we were funded for this study, is black and white treatment. Now we are right now, Jeannie can tell you a little bit more about this, but our next step, I think, is to apply a lot of these principles to a Latino population.
But potentially there are Latinos in the black and the white.
Well, the other exclusion of the study is that you have to be able to speak English, so non-English speakers were out. So if there are, for instance, Caribbean blacks in here, then they have to be fluent in English, and my guess is that there are very few.
But it was self-identified black and white patients. So it was self-identification, black and white, that were recruited.
That are recruited, right? But then for the whole population, it's just based on codes data and how they classify.
Right. Skip.
How are you, Sam?
Good.
Your question about how do we keep this going, and I've had conversations with Beth, and, one of her roles is to really identify, because navigation is essentially new, it's evolving, and there's multiple different types of navigations and navigators. There's RNs, there's social workers, there's non-clinical people, and, what we've talked about is the impact that the real-time registry has in shaping the scope of what the definition of a navigator is and the role that would play. And I guess one of the questions we would have is, when might the real-time registry be ready for prime time? I think that's probably a key element of not only us, but UNC to share this wealth of wonderful information with many, many others as well.
Yeah, and the problem with the real-time registry is that we've had to tailor it for the specific EHRs in the study. And it would be much more effective here at Cone if we got the workflows right, where people were putting in the right data.